Hello, I'm Dr. Clark Brewer with Emergency Medical Specialists, and I'm here to propose that we change and synchronize the airway carts at all of our low-volume healthcare facilities here in southern Colorado. A little bit about myself: I'm a Colorado Springs local, graduated from Air Academy High School, go Cadets, then attended University of Colorado, Colorado Springs, go Mountain Lions. I went to medical school at Medical College of Wisconsin in Milwaukee, Wisconsin, and completed a residency in emergency medicine at the University of Wisconsin-Madison. Go Badgers! Our group at Emergency Medical Specialists currently provides quality emergency medical care to those in need throughout our community. We practice emergency medicine in a variety of healthcare facilities and a variety of different physical locations with a variety of support staff at each location. Now that we have multiple unique and strategic locations such as Grandview Hospital, Pikes Peak Regional Hospital, Fountain Freestanding ER, and even our Northgate Freestanding ER, I would like to recommend that we standardize our airway cart between all these locations, aside from Memorial Central and Memorial North, as these high-volume facilities have more support staff available to the emergency medical physician. Now, here are some of the brief objectives I would like to cover as I speak to you today about our enhanced airway cart. First, I would like to briefly review some hypothetical cases that we all have encountered. Then I'd like to briefly touch on the theory of cognitive unloading and how this is beneficial to us as emergency medicine providers. Then I'd like to go somewhat in-depth reviewing the current airway cart, then reviewing the new proposed airway cart, and finally, I will conclude with a call to action to implement change in our airway cart setup. Now, let me pose several hypothetical cases that we have all encountered in the past that may require an emergent and/or urgent intubation. First, a 67-year-old male presents from home via EMS with acute flash pulmonary edema, and EMS has placed him on BiPAP. Second, a 6-year-old boy is carried in from the main entrance by his father after a random act of violence and a gunshot wound to the child's abdomen. Third, a 25-year-old female presents via private vehicle in respiratory distress from an insect sting, causing severe anaphylaxis and edema of the upper airway. Now, imagine that you have the same scenario, but now let's change the rules a little bit. Now imagine these patients present to the Fountain Freestanding ER at 2 a.m. and it is you, a brand new float nurse who you've never met before, and your favorite technician. I know, this is what we love to do as emergency physicians, but it can be stressful even thinking about these situations, especially when we think about practicing outside of our familiar environment and without our familiar tools and familiar supplies. Have you ever heard of the term cognitive unloading? I hadn't until I started listening to the teachings of some of the faculty at the Difficult Airway course. But one simple form of cognitive unloading is being able to perform a task with little cognitive input. For example, at your small ER, if your airway cart and intubation equipment is simple to use, intubations are easy to prepare for, and if this equipment is familiar and standardized across all your provider's facilities, then the emergency medicine physician can cognitively unload some of their activities of intubation and use that available cognitive ability for other vital tasks of the resuscitation, such as ABCs, mobilizing resources, and arranging for early transfer. I walked into one of the freestanding ERs the other day, and after talking to the ED provider, the nurse, and the tech that were working at that moment, they all seemed very enthusiastic about such a proposal of a new airway cart. And to be honest, none of the staff, myself included, had any idea about what type of resuscitation equipment was available in the current code cart, and none of us knew where we could find the equipment in the cart. What surprised me was that there were mixed ACLS and ATLS resuscitation equipment, such as Zoll defibrillator, ACLS medications, IV fluid bags, thoracostomy trays, central line kits, etc., all mixed into the same cart and intermixed in between shelves in the cart. I can't imagine me personally trying to look for my intubation equipment at the same time the nurse is fighting for elbow room so that they can get their cardiac monitor set up, grab resuscitation medicines, etc. And sure enough, on the top drawer was some intubation equipment, but not what we like to use and not what we are familiar and comfortable using. Now, you might think to yourself, as you're looking through this cart that you've seen for the first time, oh, I've got some laryngoscope blades. They look a little antique, but I've used something like this in the past. Okay, here are some endotracheal tubes. Oh great, it will take a while to find the right size. Oh well, this seems to be good enough, I suppose. Let's intubate. Wait, did I find a stylet? Where's my respiratory therapist? Oh yeah, I'm at a freestanding ER with just one nurse and one tech, and I have to set up my own Airway equipment, and all the responsibility is squarely on my shoulders. Now, if you imagine yourself in this scenario, I know it would be very easy to say, well, I only work one shift a month at this location, and if I ever needed an emergent intubation, my nurse and tech would know where everything is in the cart and will help set it up. Well, remember, in my pop-in visit to this freestanding ER to take these photos, none of us knew what supplies were available to use, let alone where they were located. But let's take a little bit closer look into each of these drawers to fully see what we have available to us. In the first drawer, great, you found your ACLS resuscitation medications. You've got your crash dose epi, amiodarone, and hey, here's where your dopamine is kept as well. While looking into the second drawer, I start to see things that look familiar that I'll probably need for my intubation, although I'm starting to get sensory overload by all the different items and all the different objects in this drawer. You see familiar objects such as a laryngoscope blade, several laryngoscope handles for direct laryngoscopy, and you even see lots of wrappers and plastic, some of which are labeled nasopharyngeal tube and oropharyngeal airway. But all these items are not clearly labeled, not very organized, and there are lots of varieties to choose from of each object, making for more cognitive burden than is necessary given the emergent situation of your hypothetical patient that is laying in front of you. Moving down to the third drawer, you again find something that looks kind of familiar, but there's about 20 different choices to choose from as you find your endotracheal tubes. There's some other odd-looking objects in this drawer, but it doesn't look familiar to you, and you're pretty sure you're not going to use it for this emergent intubation. As you open the fourth drawer, you realize nothing in this drawer probably pertains to this intubation, as it is full of bags of IV fluids, IV tubing, and even tubes for blood draw. The fifth drawer you open contains lots of fancy packages that again have small print on them, and you initially are unsure of what their use is. However, after looking closer, you realize this is your central line kit, and you also realize that you have things such as ED tracheostomy kit, thoracostomy tray, and thoracostomy tubes. And finally, in the very last drawer, at the bottom of your cart, you see a familiar yellow bag that is your EZ-IO gun. However, tucked in the very back corner underneath your IO, you see something that looks familiar, and you open up the package to realize this is your one piece of video laryngoscope in the entire cart. Unfortunately, it is in the very back of the very bottom drawer, and most likely would have gotten missed during an emergent rush situation. Oh, and at some point, looking through all these drawers, you found a whole slew of King LT extraglottic airways that were strewn throughout these drawers. Oh, and one more thing, this freestanding ER is equipped with suction. Kind of an inside joke amongst our group at our monthly staff meetings over frustration of not having suction available at each facility. Okay, is your head swimming yet? Are you very stressed even thinking about our hypothetical patients? Well, let's shift gears here a little bit. Let's cognitively unload, and now let's dive in to the new proposed easy-to-use Airway cart. Okay, now check this out. You have a separate Airway cart just for Airway procedures. The top drawer is probably all that you will need for an intubation. Oh, and you should lift out the top drawer and place it on the Mayo stand near the head of the bed, or on the counter while you prepare your equipment. Remember, let's keep it simple. You open the top drawer of the new easy-to-use Airway cart, and you take a nice, deep, relaxing breath in as you see familiar equipment that you've used before with minimal selection to choose from, and you know this will be easy to prepare and set up. Here's an exact list of the contents of this top drawer, which we'll refer to as the kit dump drawer. Oh, and of note, your bougie will be easy to reach as well, but is not included in this kit dump. Again, you look over this easy-to-use first drawer, and your eye is naturally drawn to your oropharyngeal airway and nasopharyngeal airway. Next, you notice that your favorite GlideScope rigid stylet and your malleable stylets are right next to your most common endotracheal tube sizes. And then you also see that, hallelujah, your 10cc syringe is easy to access as well, and while you're loading your stylet, you also load your syringe, knowing that you're going to have to inflate your endotracheal tube cuff instead of respiratory therapy inflating it for you. Oh, and just in case, you also have within reach your adult size 4 laryngeal mask airway or extraglottic device. Now, there is one modification that I am going to change to the photos seen here. I'm going to implement that we add a McGrath video laryngoscope with the McGrath Mac 3 and a McGrath Mac 4 blade into this top drawer, and it'll look something very similar to this. Most of us at Memorial Central and Memorial North are very comfortable and very familiar using the McGrath video laryngoscope. P.S. Did I mention that you should just lift up the top drawer and put it on a Mayo stand or the counter while you're preparing for intubation? Taking a look into drawer number 2, you will find additional rigid and malleable stylets, in addition to direct laryngoscopy handles, batteries, a slew of Mac and Miller direct laryngoscopy blades, and additional McGrath Mac video laryngoscope blades to choose from. This second drawer is where you go to find supplies for pediatric intubations, infant intubations, and neonatal intubations. The drawer has a well-organized, easy-to-choose, vast selection of cuffed and uncuffed endotracheal tubes. In the fourth drawer, you will find a vast selection of easy-to-use extraglottic devices, such as these laryngeal mask airways. In the other cart, we had stocked King LTs. However, in my opinion, the LMA is easier to use than the King LT. Another benefit of the LMA is the easy-to-use size chart on each package, so in the heat of the moment, you can accurately decide what size product to use if needed. In the fifth drawer, you will find more specialized airway products, such as a McGill's forceps for any potential upper airway obstruction, and other specialized equipment such as endotracheal tube exchanger, which we most likely will take out of our cart. And finally, in the last drawer of our new easy-to-use airway cart, you have the last resort. You say this jokingly, but this drawer really is your last resort, and it includes your cricothyrotomy tray and your jet insufflation and needle cricothyrotomy kit. Now, let's take a moment and step back and think about why we organized this cart the way we did. About a year ago, University of Colorado Health Department of Emergency Medicine Chair Richard Zane offered a free advanced airway course to all ER physicians affiliated with UC Health. Dr. Zane flew in the special instructors from the Difficult Airway course, and we had a wonderful 10-hour CME course that dealt with a broad range of difficult airway topics, theory, and simulation. The course again was taught by the Difficult Airway Group, which was founded by Dr. Ron Walls and uses the Walls Manual of Emergency Airway Management. In this course and in the Manual of Emergency Airway Management, Dr. Walls refers to the difficult airway algorithm and the crash airway algorithm. I would like to show you how this new proposed airway cart coincides with the difficult and crash airway algorithms. If you have time to set up for an RSI with appropriate pre-oxygenation, great. Use your top drawer dump kit. If you have to jump to a crash airway and just need a secured, cuffed endotracheal tube in your patient as soon as possible, great. Use your top drawer dump kit. If you are unable to oxygenate after several attempts at intubation, go down to your third drawer with LMAs, or use your LMA from the top drawer dump kit. If you are unable to oxygenate despite going down your difficult airway algorithm and your crash airway algorithm, then you will need to go down your failed airway algorithm and go to the bottom drawer of your cart for a surgical airway. Another perspective is, it's all good, this is getting sketchy, crap is hitting the fan, and this is my last resort. My intent with this proposal is to relay to you that this setup is congruent with the most current airway teachings and equipped with modern airway technology that most of us have used and feel comfortable with. My intent is also somewhat selfish, as I personally am going to be the physician staffing some of these low-volume ER facilities, and this is the equipment that I want. This is the equipment I want for my colleagues, as I truly believe it will decrease time to intubation, decrease adverse events associated with the high-risk procedure of intubation, and I truly believe it will save lives. Thank you for your time and attention. We covered a lot of material. We spoke about hypothetical cases that may be encountered with limited resources. We reviewed the current airway cart contents at one of our freestanding EDs, and we reviewed the theoretical new proposed airway cart and correlated its systematic use with our advanced airway algorithms. Next step would be obtaining input from key members of emergency medical specialists, such as the group president and/or board members, to give the final approval and move ahead with this project. We could then pick a few key providers to review the proposal and add additional input. After our supply list is finalized, we would then need to have our nursing managers and purchasing managers for these various locations coordinate on a large purchase of 6 carts and all the supplies needed to fill these 6 carts. I am unsure of the total expected cost at this point, although a very crude estimate would be $4,000 to $6,000 per cart. But in all seriousness, and I'm sorry to put things in this perspective, but how can you put a price on potentially preventing a death or potentially preventing an anoxic brain injury by ensuring that all of our ER physicians are set up for success with the correct equipment in an easy-to-use and familiar setting? As this project gains momentum, other people to consider involving would be the prior supply purchasers of Grandview Hospital, Pikes Peak Regional Hospital, and our freestanding ERs. Also, you would need to create a small footprint in each resuscitation room to account for the new airway cart. After transitioning to a fully dedicated airway cart, the remaining equipment in the ACLS and ATLS code cart can then be reviewed and reorganized as well. Oh, and we ran out of time, but briefly, here's some of the literature and data supporting video laryngoscopy compared to direct laryngoscopy, in addition to comparison of various video laryngoscopes and their performance. Thank you for your time and attention. Please feel free to rewind, pause, and zoom in on any detail of this presentation. I look forward to receiving your input and opinions about this project. Thank you again for your time and attention, and happy intubating.